Question number 146, we've got a 22-year-old female, presents with 6-month history of generalized abdominal pain, which is relieved by defecation, bloating, and loose stool. She denies any weight loss or blood in her stool, so we don't have any alarm symptoms. She's unaware of any foods that set her symptoms off. She does admit that she's finding work stressful. Which of the following is the most likely diagnosis? So we've got pain that's relieved by defecation. We've got stress. We don't have any alarm symptoms. So we're going to go for irritable bowel syndrome. So IBS, characterized by discomfort, which is accompanied by change in bowel habit. So you need to investigate thoroughly to exclude all other causes of the symptoms. And then management is usually we go for dietary advice, regular meals, drinking plenty of fluids, avoiding alcohol, fizzy drinks, high fiber food. You can give laxatives for their bouts of diarrhea. You can give loperamide if they're having, laxatives for the bouts of constipation, loperamide for the bouts of diarrhea. And sometimes agents such as TCAs and SSRIs have been found to be helpful. Question 147, a 50-year-old female with rheumatoid arthritis complains of pruritus, ꕰ괂 lesions around the eye, and hepatosplenomegaly. Her family thinks she looks yellow. Which of the following is the most likely diagnosis? So we've got a middle-aged female who's jaundiced, is itching, and then she's got rheumatoid arthritis, so another autoimmune disease, ꕰ괂 lesions, and hepatosplenomegaly makes us think of primary biliary cirrhosis. So primary biliary cirrhosis, middle-aged women, you can get complications of cirrhosis and portal hypertension, you can get ꕰ괂, you get hyperpigmentation, hepatomegaly, splenomegaly. Main symptoms are middle-aged women complaining of fatigue, itching, jaundice, right upper discomfort. The hallmark is that they usually have the anti-mitochondrial antibodies, and then the treatment goal is to slow down the rate of the progression of the disease. However, the mainstay of treatment is usually liver transplant. Question 148, we have a 35-year-old gentleman who asks his GP for advice regarding his ulcerative colitis. He has had pancreatitis for the past 20 years and has read online that he is at increased risk of developing colorectal cancer. Which of the following is the most appropriate recommendation regarding his appropriate surveillance? So when you've had an inflammatory bowel disease for more than 10 years, then what we need to be doing is colonoscopies with multiple biopsies every year to 5 years. Question 149, we have a 40-year-old female with a long history of ulcerative colitis who presents with pruritus and fatigue. Her LFTs are abnormal. Which of the following is the most likely diagnosis? So, seeing as we've got ulcerative colitis and inflammatory bowel disease, and now we have abnormal LFTs and signs such as pruritus and fatigue, then it has to be primary sclerosing cholangitis, which is associated with both ulcerative colitis and Crohn's, but more so with Crohn's. And we particularly suspect it when we get these symptoms and when we do our LFTs and we have a raised alkaline phosphatase. Question number 150, a 70-year-old male who has 4 days post coronary artery bypass grafting, presents with abdominal distension, vomiting, loss of appetite, hasn't passed flatus or feces post-operatively. His abdomen is distended, absent bowel sounds. Supine abdominal X-ray shows distended small and large bowel loops. What is the most appropriate management? So like we said, we've got the stigmata of sort of intestinal failure, which is the vomiting, the distension, not passing the wind, the pain. It's not bowel obstruction here because we don't have bowel sounds and he is post-operative, and we do have air in the entire sort of bowel tract, don't we? Small and large bowel. So mainstay of treatment is going to be dripping and sucking, which is keeping nil by mouth, giving the fluids via his veins, and inserting an NG tube if he is vomiting. So he's got, a post-operative paralytic ileus, and it's ileus of the gut that persists for more than 3 days. It has lots of causes such as sepsis, drugs, metabolic causes, and we said what they usually, and then most cases just resolve with watchful waiting and supportive treatment. Question 151. A 20-year-old female presents with short stature, rounded face, shortened fourth metacarpals of the hand and feet, obesity, serum calcium is low, and parathyroid hormone levels are elevated. Which of the following is the most likely diagnosis? So we've got these structural abnormalities, which are very, very characteristic. The short stature, the rounded face, the shortened fourth metacarpals of the hand and feet, obesity. We've got low sodium, calcium, and elevated parathyroid hormones. So it has to be pseudo-hypoparathyroidism. So which is the resistance to the parathyroid hormone. Like we said, they have the characteristic structural abnormalities, and it has the high parathyroid hormone because we're resistant to it, low calcium, high phosphate, and a normal alkaline phosphatase. If we were talking about primary, secondary, tertiary hyperparathyroidism, we're obviously going to have high parathyroid levels. The amount of calcium and phosphate varies, but characteristically we have a high level of alkaline phosphatase in secondary and tertiary hyperparathyroidism. When we have primary and secondary hypoparathyroidism, we always have a low parathyroid hormone. When it's primary, we'll have low calcium with that, secondary high calcium. Phosphate is always high, and alkaline phosphatase is always normal. Question 152, we have a 45-year-old male publican, which means that he owns a bar, presents with severe upper abdominal pain that lasts for several hours after meals. He's got weight loss and foul-smelling stools, i.e. steatorrhea. Which of the following is the most likely diagnosis? We've got alcohol intake, severe abdominal pain, weight loss, steatorrhea. It has to be chronic pancreatitis. So, and characteristically, the pain is sort of in the upper abdomen, radiates to the back, and they're relieved by lying on their side and flexing their knees up. A small percentage of people have painless pancreatitis, but they present with pancreatic, exocrine, or endocrine insufficiency. Question 153, we have a 35-year-old female with pernicious anemia who complains of feeling weak and faint. She's hypertensive and she has a raised potassium, so that is an alarm, okay? So we've got somebody who's got pernicious anemia, means she's got autoimmune disorders, and autoimmune diseases come hand in hand, don't they? With the high potassium immediately makes us think of Addison's disease. So it's what is Addison's disease? It's an adrenocortical insufficiency that affects both glucocorticoids and mineralocorticoid function. So symptoms, usually the first symptom is hyperpigmentation, and that's because the ACTH hormone stimulates melanocytes to produce melanin. You get the hyperpigmentation usually in the mucous membranes of the oral cavity, or you get it in areas that are exposed to the sun. Other findings are they have vitiligo, which is another autoimmune disease, and their symptoms relating to the Addisons are usually the weakness, fatigue, poor appetite, weight loss, abdominal pain, nausea, vomiting, diarrhea. They become hypertensive, and then usually when we check our serum usinase, they have a very high potassium. Question number 154, we've got a 50-year-old female who presents with enlarging, painless midline neck swelling. It feels symmetric, enlarged, soft, moves on swelling, but not on tongue protrusion. thyroid function tests are normal. So seeing as we've got thyroid function test normal, that excludes toxic nodular goiter, doesn't it? Seeing as it's midline, it wouldn't be a ∤ cyst, it wouldn't be an enlarged lymph node, and it wouldn't be a cystic hygroma in somebody this old, so it has to be non-toxic goiter. So, and most importantly, we've got normal thyroid functions. It can be two types, can be endemic and it can be sporadic. Endemic is when more than 10% of the population have it. Causes are iodine deficiency and goitrogens, such as drugs such as lithium, propylthiouracil, foods, sometimes dysharmoniogenesis, which is a defect in the thyroid hormone pathway, or if we have childhood head and neck radiation. Question 155, we've got a male who is a type 1 diabetic. He presents in a DKA coma to A&E. His serum glucose is 25, sodium is 141, potassium is 3, urea is 3, creatinine is 100, chloride is 102, bicarb is 10 millimoles. It's asked us to estimate the anion gap. Anion gap equals positive minus negative. So that's going to be just our sodium and potassium together added minus the total of our chloride and our bicarb. In this case, answer is 32. We've got a rather big anion gap, which indicates that we have increased presence of acid, which is being buffered by our bicarb. Question number 156, we've got a 24-year-old female who has a history of asthma and presents with symptoms of hypothyroidism. Which of the following would be the most appropriate first-line management? So she's asthmatic, so that rules out our propranolol, we wouldn't give thyroxine because she's already hypothyroid, isn't she? So first step would be our medical management, our carbimazole, and then we could move on to either our surgery or our radiotherapy. So symptoms are weight loss, palpitation, diarrhea, increased appetite, heat intolerance, sweating, tremors, irritability, emotional liability, oligomenuria, tachycardia, lid lag. Like we said earlier, propranolol is contraindicated because of the asthma, and then other treatment options which you may think about after trying our medical management usually are partial thyroidectomies and radioiodine therapy. Question number 157, we've got a 72-year-old male who presents with weight gain, weakness, bruising, overnight dexamethasone suppression test has completely failed to suppress cortisol level. He doesn't have ACTH, so which of the following is the most likely diagnosis? So here we're going to think of primary Cushing's syndrome, and I'm going to tell you why in a bit. So when we do our dexamethasone suppression test, we do two tests. We do the low-dose dexamethasone suppression test and the high-dose dexamethasone suppression test. If we do the high dose and the low dose and our cortisol is not suppressed at all by either the high or low dose, then we have two different differentials to think about. It's either primary Cushing's through an adrenal adenoma or it's ectopic ACT. And the way to sort of pick which of the two is by doing an ACTH test. If you don't have any ACTH, that means you have an adrenal adenoma that's secreting the cortisol out and suppressing the ACTH. If you have an elevated or normal ACTH level, that means you've got ectopic ACTH. If your dexamethasone suppression test is suppressed by the high dose but not the low dose, then you think of Cushing's disease, which is a pituitary adenoma, and you'd next need to do a MRI to do that. So I hope that's clear. So that's why we're thinking about adrenal adenoma. We're not thinking about Addison's because that means you don't have cortisol at all. You wouldn't need to be doing all this. In cons, it's completely different. It's got something to do with aldosterone as opposed to cortisol. Question number 158, we've got a 45-year-old male who, with known vitiligo, presents with weight loss, dizziness, and fatigue. On examination, she is hypertensive and has hyperpigmentation on the extensor surfaces of her skin and mucous membranes, which is the most appropriate investigation. So she is shouting out to us of having vitiligo with her weight loss, dizziness, fatigue, hyperpigmentation. So then we're going to do the short ACTH or synacthin stimulation test. So what happens is we give our ACTH, and that activates cholesterol esterase enzymes. So within giving the ACTH infusion, and normally working adrenal cortex should release 25 times the amount of the cortex that was already out there. If it doesn't change, that means your cortex isn't able to secrete cortisol, which means you have Addison's disease. Question number 159, we've got a 56-year-old woman who has presented to her GP complaining of tiredness, shortness of breath, loss of sensation in her feet. On examination, she's pale, she's jaundiced, she's got glossitis, she's lost joint position sense and vibration distally with extensor plantar reflexes, absent ankle jerks and brisk knee jerks. So what's the cause of her symptoms? So we've got somebody who's got an anemia, she's got glossitis, and she's got subacute combined degeneration of the cord, where we've got the posterior and lateral columns of the cord affected. The only thing that can sort of produce this picture is B12 deficiency. Yep, so we've got anemia, our glossitis, our peripheral neuropathy, plus our subacute combined degeneration of the cord. Question number 160, we've got a 40-year-old woman who presents to the GP with history of weight loss and irritability. She has lost 6 kilos in the past 5 weeks. Her appetite is normal. Weight loss is unexplained. She's also complaining of blurring of vision. She's got a staring look with lid lag and lid retraction. So weight loss, the staring look, lid lag, lid retraction. So that shouts out to us that she's got Graves' disease. Graves' disease is the commonest cause of the hyperthyroidism, and what happens is we have antibodies, and we start thinking about Graves' disease when we get the ophthalmological symptoms such as periorbital edema, conjunctival irritation, exophthalmos, and diplopia. What happens is we get IgG immunoglobulins, which stimulate the TSH receptors of the thyroid. And the reason why we get the proptosis, ophthalmic lesion, and the periorbital edema is because we get antibodies which are directed against the retroorbital structures.